The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and welcome to another edition of the RX Question Lab. I'm Jeff Downing, and it is my distinct pleasure to guide you through an active learning session focused on the gastrointestinal system, one of those key areas for step one. I am joined tonight by Kate, who is going to be answering questions. So we're happy to be here. We know that as you know, tonight we're going to dissect some board style questions specifically designed to test your understanding of some GI physiology, pathology, a little bit of pharm. So we're going to explore some scenarios, try to unravel some questions, and just, more importantly for us, kind of delve into the the reasoning here behind the answer choices. Okay, so obviously our approach is not just about getting it right, it's about understanding the why and the how that underpin clinical decision making. Okay, so with that, one thing I want to just note is that what we're going to be walking you through is our methodology for answering questions. And this is something that we've used here at USMLE-Rx and our tutoring service, RX Coach. And the idea is that, when you are going to take a self-assessment exam, or when you're taking, even some of your practice tests, that your goal is to, answer the questions in the way that you plan on answering them on test day, and so really getting into the habit of taking each question and answering it methodically. It's a key towards being successful on test day. So as we walk through this, I'm going to just talk about some of the steps. You don't necessarily have to follow each one. Everyone probably has their own approach, but we think that in order to operate as efficiently as possible on test day, that it's good to say, to yourself, hey, this is how I'm going to approach every question, just so that you're consistent and that you don't make mistakes, and that you're not thinking about how you're going to answer a question, that you're just doing it. Okay. So with that in mind, I'm going to open up question number one. And the first thing you're going to see is that there's something missing, right? We have covered up all of the answer choices. Again, this is by design. We feel like there are a lot of things that can throw you off if you start looking at the answer choices too soon, right? You might see maybe you see a drug that you've never studied, or you see a bug that has taunted you in the past, right? There's all kinds of things. We just don't, when you're attacking the question, we want you to, again, do it in a way that is, consistent and efficient. So we say cover up the answer choices first. And then step two, we want you to go ahead and read the lead-in. And the lead-in is the question part of the item, right? So in this case, the lead-in is: the new medication that increased the risk for the patient's gastric findings has which of the following mechanisms of action? So again, by reading the lead-in, now you understand what you're looking for. You know what the question is, right? And what some of the things that you're going to need to parse as you read the vignette, right? If you read the vignette first, it's all, you're taking it in cold. By reading the question first, it's already given you some clues as to what you should be on the lookout for. Okay, so with that, let's go ahead and read the vignette. A 60-year-old man comes to his primary care physician because of abdominal pain and dark stools for the past 3 days. He has a history of gout and osteoarthritis that is managed with allopurinol and ibuprofen as needed. 2 weeks ago, he was given prednisone for a short period to control a flare of gout. Abdominal examination reveals mild epigastric tenderness. Stool is heme positive. upper gastrointestinal endoscopy reveals hyperemia of the gastric mucosa and the presence of numerous linear ulcerations with evidence of bleeding. So again, the new medication that increased the risk for the patient's gastric findings has which of the following mechanisms of action? I need to take a minute. Let me, and I hear some folks are saying that they're having issues hearing me. Um, if you are having problems there, let me, I guess if you couldn't hear me, you would let me know in the otherwise. But anyway, I'm going to proceed. If you're having some issues, you may want to log out, log back in. Okay. So what we're going to do is I'm going to ask you to go to the question box. Let me know how many steps you think it's going to take to answer this question, right? Is this a one-step question, a two-step question? And let's take it from there. Okay. Now with that, let us see what our answer choices are. And when we look at the answer choices, we typically read them from the bottom. Again, being methodical, sometimes when you are, just going, top to bottom, you may see something that you like and you're like, bang, that's the one for me. When you're reading from bottom to top, you are going to just naturally going to be looking more, ensuring that you are reading each answer choice. Okay. So from the bottom, answer choice E, inhibition of xanthine oxidase. Answer choice D, inhibition of the sodium-potassium ATPase pump. Answer choice C, inhibition of the hydrogen-potassium ATPase pump. Answer choice B, inhibition of beta-tubulin polymerization into microtubules. Or answer choice A, binding and activation of intracellular receptors. Okay, so now that you've gathered all of your information, what do you think is the mechanism of action from that new medication? Okay, so I'm going to launch the poll, and I'll give you a chance to tell me what you think is the right mechanism of action. Then we'll just as a note, we will have a raffle at the end of tonight's event. Someone is going to walk away with a subscription to RX 360 Plus, and we also have a special that's going on right now. I'll tell you a little bit more about that at the end. Okay, so let's see. Over half of you have voted. Looks like we've got a clear favorite. So I'll give you a few more seconds before I close the poll. Okay, so let's see what we've got here. Almost half of you went with answer choice A, the binding and activation of intracellular receptors. Almost a quarter of you went with answer choice C, and then for third place, it was pretty much split between B, D, and E. So interesting. Let's go ahead and hide the results and reveal the answer. And the answer is answer choice A, binding and activation of intracellular receptors. Great job, everyone. That was a good way to start off the night. So, this is an interesting one. I mean, we'll talk about some of the high yield points here in a minute, but let's break it down. So, I asked you how many steps you thought it was going to take to solve this one, and I think this is actually a 3-step question, right? So, step one, what are you trying to do? You're trying to to come up with the diagnosis, right? So, this patient has hyperemia of the gastric mucosa. They've got, there's the presence of, numerous linear ulcerations with evidence of GI bleeding. So that picture suggests gastritis, and that's supported by those the heme positive stools. So gastritis and peptic ulcer disease, common causes of upper GI bleeding with epigastric pain. So, with that, I think that takes us to, step two. So we need to figure out what um, the adverse effect of the drug is. So, gastritis can be induced by, non-selective, non-steroidal anti-inflammatory drugs, NSAIDs. So here they're likely taken to relieve the pain that he is dealing with osteoarthritis. So you've got this adverse effect, which is amplified and worsened by also taking glucocorticoids like prednisone, which are sometimes given for severe arthritis inflammation, which can be seen in gout. So taking glucocorticoids along with NSAIDs doubles the risk of that NSAID induced GI side effects. So this brings us to step three, right, which is figuring out that the drug mechanism. So the glucocorticoids, they bind and activate intracellular glucocorticoid receptors, and suppress the immune system response to multiple inflammatory conditions like gout, right? So let's look at those other answer choices here. I'll jump back here for a second. So going from the bottom, inhibition of xanthine oxidase, that describes the mechanism of action of allopurinol, which is a medication used to treat gout. Allopurinol reduces the body's production of uric acid, and side effects include drug rashes, which not seen here. The let's see, answer choice D. This describes the mechanism of action of digoxin, and that's an inotrope used as a backup drug for severe congestive heart failure. Not relevant here. Answer choice C. You've got the this really describes the mechanism of action of proton pump inhibitors. So major adverse effects of the PPIs include nausea, headache, and abdominal pain. So not all of those show up here. And then answer choice B, the inhibition of beta tubulin polymerization into microtubules. This kind of describes the mechanism of action of colchicine, which is a medication used to treat gout flares when other meds are contraindicated or just don't work, right? So this may cause diarrhea and cytopenias, liver failure, and neuropathy with prolonged use. Okay. So again, just kind of a quick breakdown. The non-selective NSAIDs, such as naproxen, ibuprofen, significantly increase the risk for gastritis, peptic ulcer disease, and upper GI bleeding. And that the risk is increased by adding glucocorticoids in the treatment. Inhibition of COX-1 by non-selective NSAIDs reduces the production of prostaglandins in the GI tract, and that compromises the protective gastric mucosal layer and can lead to ulceration and gastritis. And of course, glucocorticoids activate the intracellular glucocorticoid receptors and suppress the immune system response. Okay, so there's your key takeaway for question number one. Okay, great job. We are off to a good start. Let us move to question number two. And here you've got we've already got a little gram stain for you to take a look at. So again, we've covered up the answer choices, and we're going to start by looking at the lead-in. Which of the following is the mechanism of the toxin most likely responsible for this patient's diarrhea? Okay, so again, we know we've got a patient with diarrhea here. We've got a gram stain we're going to be looking at, so let's read the vignette. A 45-year-old woman comes to the emergency department because of severe watery diarrhea for the past 3 days. She recently returned from a trip to rural Asia. On physical examination, she has diminished pulses, sunken eyes, and poor skin turgor. A gram stain of her stool is shown. The organisms are oxidase positive and non-lactose fermenting. Okay, so take a look at that gram stain and think, which of the following is the mechanism of the toxin most likely responsible for this patient's diarrhea? Okay, so you can go down to the question box. Let me know how many steps you think it's going to take to answer this one as I reveal the answer choices. And again, we will read them from the bottom. So answer choice E makes a bacterial adenylyl cyclase to increase host CMP. Answer choice D disables the G protein GI subunit. Answer choice C activates toll-like cell surface receptors. Answer choice B activates guanylyl cyclase, or answer choice A activates adenylyl cyclase. Okay, think about that. Take a good look at your gram stain. And what we're going to do is we're going to launch the poll. What do you think out of these choices is the mechanism of the toxin most likely responsible for this woman's diarrhea? Looks like you guys are jumping all over this one. So far, so good. I'm seeing strong support for one of the options. About half of you have voted, so let's give you a few more seconds. Let me know what you think. Okay, I'm going to get ready to close the poll. 3, 2, 1. Okay, let's share the results. Okay, so again, almost half of you went with answer choice A, but answer choice E, strong showing. Almost a third of you went with that one. Okay, let's go ahead and hide the results and reveal the answer. And once again, you guys nailed it. Answer choice A is correct. Activates adenylyl cyclase. Okay, so let us, break this down, right? So, again, kind of, take a look at your patient there. 45-year-old woman comes to the emergency department. She's got severe watery diarrhea for the past 3 days. She's been traveling, so a lot of strong signals here, and so step one here is diagnosing the disease, right? So based on this presentation, the symptoms of watery diarrhea and severe dehydration. So you see the dehydration there in the diminished pulses, the sunken eyes, the poor skin turgor, right? Traveling abroad to a rural region where Vibrio cholera is endemic. Most likely, it's a Vibrio cholera infection, right? So the stool culture here. So we know that it's gram negative. It's non-lactose fermenting, oxidase positive, but it's comma shaped, right? So the comma shaped organisms there, that's a clear sign there of Vibrio cholerae. So you got the disease. Now we need to answer step 2 here, which is figuring out the disease mechanism. So the Vibrio cholerae toxin, ADP, right? So this ribosylates the G protein GS alpha subunit, and that in turn is going to activate adenylyl cyclase. Okay, and this is going to increase CAMP levels and overactivates protein kinase A. So protein kinase A then phosphorylates the CFTR chloride channel, and that increases chloride excretion into the GI lumen and causes the subsequent H2O efflux and the characteristic rice water diarrhea. Okay, so that's what's going to lead you to that answer choice. Looking at the other choices here, answer choice B, the heat stable toxin of the enterotoxigenic E. coli, which is a lactose fermenting organism, that is what activates guanylyl cyclase. Okay, E. coli causes diarrhea, but is actually lactose fermenting. Thinking about answer choice C, you've got the what's going to activate the toll-like cell surface receptors. That would be something you would see with lipid A, and that's a component of gram-negative bacterial cell walls. So lipid A is going to activate the toll-like cell surface receptors and can cause like vasodilation and hypotension. Answer choice D, the pertussis toxin produced by Bordetella pertussis is what disables the G protein, the GI subunit. And sorry, that I should be a kind of subscripted in the question, but that would cause whooping cough. And then the edema factor produced by Bacillus anthracis, that makes a bacterial adenylyl cyclase to increase host CAMP. B. anthracis causes fever and vomiting. Don't see that here, and sometimes diarrhea, but this one is a gram-positive rod. Okay, so a lot there, a lot of wrinkles. Most of you, seem to be on the right track there. So great job, everybody. We're halfway through tonight. You guys are doing really well. So I'm going to move us on to our next question. But again, you got your high yield summary. Here are your key takeaways for this one. Vibrio cholerae is going to cause severe watery diarrhea, may cause severe dehydration, non-lactose fermenting, oxidase positive, comma-shaped, and gram-negative organism, and it secretes a toxin that irreversibly activates Gs, which in turn activates the adenylyl cyclase and increases CAMP levels and overactivates protein kinase A. This all leads to increased chloride excretion into the gastrointestinal lumen. Okay, very good. So we're halfway home. Let us take a look at question number 3. Again, we're going to have a raffle at the end of tonight's session. You don't really have to do anything. You're already here, so we're only going to be drawing names from those that are in the crowd. So you have to be here in order to win. And we've got a couple of other things to tell you about. So let us jump in here to question number 3. So, again, you can see the CT scan already available for you, and a really heavy vignette, right? So certainly in situations like this, it's imperative to read the lead-in first, right? So let's do that. Which of the following is the pathophysiologic cause of this patient's most likely condition? Okay, so again, figuring out what's going on here. It's going to be key. Let's read the vignette. A 70-year-old man presents to the emergency department with a 3-day history of worsening lower abdominal pain, nausea, and fever. He had 2 episodes of similar pain in the past 3 years. However, the pain was less severe and resolved within 2 days. History includes hypertension, hyperlipidemia, type 2 diabetes, mellitus, and constipation. Temperature is 38, pulse is 96, respirations are 17 a minute, and blood pressure is 145/82. On physical examination, the patient is in moderate distress. Abdominal examination reveals tenderness to the left lower quadrant with some voluntary guarding, but no rebound tenderness. CT of the abdomen is shown right here. Serum white blood count is 15,000. So again, which of the following is the pathophysiologic cause of this patient's most likely condition? Okay, so again, head on down to the question box. Let me know how many steps you think it's going to take to solve this one. As we, again, kind of, stepping through this one. Look at the age of the patient, where he's presenting. Take a look at the history, what those symptoms look like. Look at his past history. A lot of key clues here that I want you to home in on. Okay, with that, let's go ahead and take a look at the answer choices. And what I'm going to do here is I'm going to read them from the bottom. Answer choice E, twisting of the sigmoid colon about its mesenteric base. Answer choice D, malignant cells invading one of the vessels supplying the colon. Answer choice C, increased intraluminal pressure leading to microperforation of a bowel outpouching. Answer choice B, idiopathic transmural inflammation of the distal colon. And answer choice A, bowel infarction. Okay, take a look at those answer choices. When I launch the poll, you're going to notice that answer choice C is cut off. I've got a character limit here, so just make sure you get a chance to look at all of these here one more time here before I launch the poll. Okay, so here we go. Go ahead and take your best shot. Remember, on test day, you don't want to leave any questions unanswered. Okay, so you're not going to be penalized for it. So make sure you knock them all out. Okay, let's see. How are we doing so far? Okay, off to a good start. Looks like about a third of you have voted. Looks like a number of you are on the right track. Okay, how are we doing here? Okay, almost 3/4 of you have cast your vote, so let's go ahead and close the poll and share the results. So again, we've got strong support for one of the answers. 55% of you went with answer choice C. Bowel infarction came in second place, almost 20%, and then the rest of the answer choices kind of splitting the vote. So let's see, how did we do here? Well, let me hide the results, and the answer is indeed answer choice C, increased intraluminal pressure leading to microperforation of a bowel outpouching. Great job. I think that's our our best performance so far tonight, and we're getting a little bit deeper in it. Sometimes our questions get a little harder, but you guys did great. But if you didn't get it, that's okay. I don't want to diminish the fact. We've got some tough questions in here, and we really would prefer that you get the questions wrong on Question Lab rather than test day, right? So let's walk through this one and see what we've got. So first things first, right? What's your diagnosis? taking a look at what this patient's been going through. I'll give somebody a chance to weigh in here. What do you think? What do you think they're dealing with? You can go down the question box and let me know. You've got presentation with left lower quadrant pain, fever, leukocytosis. That's a classic setup for, there you go, diverticulitis. Hats off to a couple of you for getting that one right there. And so, yeah, you've got all of those symptoms, and then the CT results really kind of confirm that diagnosis with stranding and hyperemia in the sigmoid colon. Okay, and we've got the kind of see the arrows there pointing to that within the image here. So you got the disease, you've got the diagnosis. Your second step is kind of figuring out the disease mechanism. So diverticulitis occurs when a diverticulum, which is an outpouching, right, caused by chronically increased intraluminal pressure, becomes infected. And what happens there? It leads to a microperforation of the bowel outpouching. Because they form where a vasa recta penetrates from the serosal side of the bowel, they are, they're structurally weaker than the rest of the colon. So that really leaves them vulnerable to microperforation. And all of these factors obviously increase the risk of diverticular bleeding, right? So the image, it shows diverticular disease and the area of abnormality, right? So let's take a look at our other answer choices here. And, I'm going to kind of go a little bit out of order, but the reason is like I just want to kind of touch on the things that kind of jump out, right? So bowel infarction, which quite a few of you went with, presents with acute pain. So this results from embolic arterial occlusion of the superior mesenteric artery, and that's going to be characteristic of acute mesenteric ischemia, which presents with periumbilical pain. Another one that's going to present with acute pain is answer choice E, right? So the twisting of the sigmoid colon about its mesenteric base. So that would suggest a sigmoid volvulus manifest by abdominal distension and evidence of bowel obstruction on a CT, right? Which doesn't show up here. Our other two options, so answer choice B and answer choice D, would have a more chronic presentation, right? So idiopathic transmural inflammation of the distal colon would be, characteristic of, it's going to be something that presents with chronic symptoms here, and malignant cells invading colon supplying vessels. That'd be characteristic of advanced stage colon cancer, which has a chronic presentation. Okay, so again, high yield summary here: left lower quadrant pain, fever, and leukocytosis suggest diverticulitis, and that can be confirmed by CT. Diverticulitis occurs when the diverticulum, caused by chronically increased intraluminal pressure, becomes infected, leading to a microperforation. Okay, so great job, everybody. We've done really well tonight. I'm just impressed by how well folks have been nailing these questions. We're going to do our best to close strong. So this will be our last question of the night. And again, we've got the answer choices covered up. And the question is, the lead-in is, the patient suffers from a deficiency of which of the following? Okay, so in this case, lead-in isn't telling us a lot, right? So we know it's going to be some sort of a deficiency, and it's a GI question, so you're often going to be thinking about you know, key vitamins, right? So let's look at the vignette. A 38-year-old male presents to the clinic with symptoms of hair loss, a rash, and a metallic taste in the mouth. The symptoms have worsened over the last 2 months. The patient has a history of Crohn's disease, which has required multiple small bowel resections and for which he is not receiving regular medical care. Physical examination reveals an erythematous rash around his mouth and excoriations and erythema around the anus and buttocks. Patches of no hair are visible on his scalp. So the question, the patient suffers from a deficiency of which of the following? Great. Head on down to the question box. Let me know how many steps you think it's going to take to solve this one as I go and reveal our answer choices. So I'm going to take them from the bottom. Answer choice E is zinc. Answer choice D, selenium. Answer choice C, iron. Answer choice B, copper. And answer choice A, chromium. Okay, so you've got your options. What I'm going to do is I'm going to launch the poll, and you can tell me which of the following is this patient suffering a deficiency of. Also want to note that we have a special promo going on right now. You can get 55% off new subscriptions through Thursday night. Put that in the chat box for you. Okay, almost 3/4 of you voted, so I'm going to get ready to close the poll. And we'll share the results. Okay, so a runaway in this one. 2/3 of you went with zinc. About a fifth of you went with iron, and then the rest of the votes were kind of split up. So let's go ahead and hide the results and share the answer. And the answer is answer choice E, zinc. So great job, everybody. Something was kind of jumping out at you, right? So let's take a look at this one. This is a one step. Really, you just need to be able to diagnose the disease, right? So patient is likely suffering from zinc deficiency. So what do you got? So you already have the diagnosis of Crohn's disease, right? And they've got symptoms of alopecia, perianal and perioral dermatitis, and dysgeusia, and the history of severe Crohn's disease. And so all of this is going to be able to, that can lead to malabsorption and zinc deficiency. So, zinc, I mean, just think about the role it plays in, numerous processes, right? Through incorporation as a cofactor into the zinc finger domain structure of many transcription factors. These are all obviously important in cellular growth and tissue repair, wound healing, metabolism, immunity. So, deficiency of zinc, it's rare, but it's more common in patients with diseases involving the small bowel that may affect the absorption of zinc. And because it plays a diverse role in many processes, it's going to present with various symptoms in multiple body tissues. So the dysfunctional wound healing, the perioral and perianal dermatitis, the abnormal and pleasant taste sensation, loss of smell, hypogonadism, let's see, alopecia, lowered immunity, diarrhea. All of these are, potential symptoms, right? So let's look at the other ones here. So, very few of you went with chromium. Chromium deficiency is rare, typically limited to hospitalized patients with high catabolic demands. So it typically presents with impaired glucose tolerance and dyslipidemia. The other ones are somewhat more common, but really wouldn't present with the same constellation of physical exam findings. So, selenium is going to, if you got a selenium deficiency, you might see symptoms like cardiomyopathy, skeletal muscle dysfunction, macrocytosis, probably, and just immune dysfunction. Copper. Well, let's see, copper deficiency. You're going to have abnormal and fragile hair, skin depigmentation, has some neurologic abnormalities, hepatosplenomegaly, osteoporosis. And then iron, a number of you went with iron, and obviously iron deficiency is common, and it's going to present with a microcytic hypochromic anemia that can be accompanied by fatigue and lethargy, right? So that really didn't really come through here. Okay, so again, nice work, everyone. High yield summary. They can, zinc deficiency can occur in patients with severe malabsorption, presenting with perioral or perianal dermatitis, dysfunctional wound healing, dysgeusia, anosmia, and alopecia. Okay, fantastic work, everyone.